Hello, hi, my name's Lauren, Dr. Quinn, and this is for the December webinar for the Medic Mentor Study Guide. So firstly, I'm really sorry I'm a bit late. I had a really busy day. It was supposed to be an 8-hour day and it was actually a 13-hour day. So I've literally just got back from work. So I'm sorry it's a little bit of a rush and a bit late. I can't see anybody viewing at the moment, but you should be able to access this at a later date. We are looking to make it available for you. So do join. Make sure you join us another time if you know. So I hope you all had a chance to have a look at the December study guide. I hope you found it interesting. There were quite a nice cardiac case initially, and then talking a bit about evolution, which I found really interesting, and I think it's very much linked to medicine and to love of people and love of medicine. So I'm hoping this session might take us about half an hour just to go through some of the content. And certainly if you have any questions, we'll try and answer them as we go along for you. So let me just share some slides with you. One moment. Let me, so let me figure out how to do this. Okay, maybe it won't let me share it. Okay, right. So it's okay. The case was, I hope you all gathered, was a man essentially having a heart attack. And heart attacks very classically happen when people are active, and they do a little bit of extra activity than what they're used to, and then all of a sudden they get this sort of retrosternal, awful, heavy chest pain right in the center of their chest. And it's like nothing on earth. It takes their breath away. They feel really sick with it, a bit dizzy with it. All they want to do is just sit down and want the pain to go away. That's very classic for a heart attack. So if you ever see anybody like that, then that's probably what it is. So he was walking his dog, and then this chest pain came on. Now, the thing is, so we talked that one of the first questions for the medics was about ACS, which is acute coronary syndrome, which there are 3 different types of the syndrome. The first is like what we call unstable angina. So this is when you have got a partial obstruction of the artery, of the coronary arteries. They're the arteries that supply the heart. So essentially, when you have a partial obstruction, because you haven't got a healthy blood supply, your heart muscle starts to get a bit upset, and you start to release sort of lactic acid. It's not undergoing the aerobic respiration it normally should undergo, and that's why you get the pain. Now, so you can have the first part of ACS is your stable angina. Your second part is what we call a non-ST elevation myocardial infarction, or a form of heart attack, which is slightly different from unstable angina, because it's actually where some of the heart tissue is actually started to sort of the cells are disrupted and start to die. So you tend to get release of an enzyme called troponin, which is if it's very high, it's very specific. It can be for a heart attack. If it's in the hundreds of thousands. A lot of people can have troponin release for lots of other reasons. So sometimes you have to interpret it in the context. But if you have a troponin of 50,000, then you know that there is a lot of heart damage and potentially heart death and even necrosis. So really awful death of the heart tissue. So the ways when we're looking at a patient with a heart attack, so we do their bloods, their troponin, which is an enzyme, but we also look at their ECG, so the electrocardiogram. So I'm sure you've all seen an ECG, and it's good to know like what the components are, and you'll cover that in medical school anyway. But there's a very classic ischemic change called ST elevation, which is the ST segment of the tracing when it's elevated significantly. And that is a sign of vessel disease essentially, and a particular, usually a particular type of vessel disease. So there's three main vessels in the heart: the left anterior descending, and then you've got the left circumflex, right circumflex, and then you've got a bit of posterior supply as well. So looking at the ECG will tell you which vessel is affected quite commonly, which is helpful then, because for anybody who's had a heart attack, and then particularly a big heart attack, you want to get them to the catheter lab. So that's essentially when you see them on casualty wheeled off, and they will insert basically like a feeder wire into the artery, into the radial artery, which then goes all the way around. So it'll go from the wrist all the way down, it goes inside the artery all the way up back to the heart, and then they can stream it into the coronary arteries and view the arteries from the inside out, so they can actually see exactly where the obstruction is, how big the obstruction is, and then they can decide, do they need to, essentially what they do, they put this wire in and then they make it into like a balloon, a bit like that, so they blow it up, and then that basically, if you imagine you've got your artery here and it's a little bit blocked like that, if you're putting a balloon against it, it kind of hopefully should revascularize it, should open it up. Now that might not be permanent, in which case then they start to think about putting a stent in. So if you've got your vessel here and then you put a stent in like that, a metal stent, then that keeps the artery open and it helps protect them from heart attacks in the future. So when in the questioning, when I was talking about cath lab and angio and what all of that is our best way and our best chance of treating a heart attack. And you need to do that really quickly, because it's like time is muscle, time is tissue. It's the same with a stroke. It's exactly the same principle. The longer you leave a tissue without a blood supply, the longer, the more harm that's going to be done, the more damage, and the more permanent damage. So, you could have parts of the heart that really don't work at all anymore because of a major heart attack that hasn't been treated right. So we usually have it's usually about a 3-hour window for heart attacks that you have to be able to put a stent in when it's going to be most effective. So that's what I was talking about. That was the main part of the case, and it's very, heart attacks are relatively common. And there are the risk factors. I'm sure that you will have known of many of the risk factors for heart disease. The really big ones are smoking is one of the most important vascular risk factors. So when patients come in and tell us that they smoke, our heart sinks, and then we try and persuade them not to smoke, and it's actually a very difficult conversation because many patients, it is addictive, and if they have no will to give up, it's very difficult to persuade them. So smoking's a big one. High blood pressure as well is another really important one, and it might seem like a small insignificant thing, but over time, if you're living with high blood pressure, then it starts to have a big effect. It can affect your eyes, your brain, your heart, and your kidneys. They're the main organs affected. So blood pressure is another one, and then there are other important ones. Diabetes is another really important one. So all patients with diabetes are at high risk of all forms of vascular and heart disease, just because of the nature of high blood glucose levels running around the blood, leading to deposits and increasing risk. So I would say those are the big three. I'm sure you know of other factors, things like obesity is a contributing factor, lack of physical activity and sedentary time, so resting a little bit too much, not being active enough are contributing factors as well. And then there's other conditions that can increase your risk of vessel disease as well. But those are the big important ones. So those are what I was after when I was asking about vascular risk factors. Now, you will have noticed in the case, he also had some teeth problems. He had some teeth caries, which is essentially like your teeth are rotting away. Dr. Uppal could give you a much better explanation than I could. Now, for the time being, these webinars can only be hosted by one person. So we are looking to change the way we do it so that we can have a vet and a dental expert on at the same time, which would be fantastic. I know not all of you are medics, and you really would want that insight into the dental and veterinary side of things. So do bear with us on that. It is certainly still a work in progress. So unfortunately, I can only give you the medical side, but dental caries are often a sign of sort of underlying vessel disease, underlying poor lifestyle, and there's something to look out for and to advise patients to see a dentist. And there's no harm in that as a doctor. Our like ENT specialists, ear, nose and throat specialists don't really deal with teeth unless it needs an operation. So we certainly do rely on our dental colleagues, and in his case needed some antibiotics, which is very common. So the other element was the veterinary check, which again I think what we'll do is we'll try and make the veterinary information available to you in another means, perhaps by including it in the next study guide for you, just so that you have the answers to the questions on that. Unfortunately, Dr. Pegg is on call tonight and for a lot of the Christmas holiday, so she unfortunately couldn't join us. But that's the case. If you have any questions about the case, do let Dr. Uppal know. She is answering them as she goes along. So feel free to make it interactive. The next bit I want to talk to you about was, so we've got the SJT case, situational judgment, and the sort of the debate about evolution. So what I'll do, let me just get up the SJT case. I just want to make sure. Let me just get it for you. Here we go. Okay, and yeah, feel free to ask any questions you have. It's just loading, sorry guys. Just taking a long time. I'll tell you what, while that's loading, I can move on to the evolutionary part, which like I said earlier, I find evolution really interesting. And I had some really nice pictures for you, but unfortunately my PowerPoint isn't displaying, unfortunately. I can't seem to share it with you for some reason. But what I wanted, so I think if you want to know more about evolution, Professor Alice Roberts is fantastic. She's did a whole BBC series that you can get very cheap on Amazon, and I've watched them all and loved them. And the amazing thing about humans and our species is called the Homo sapiens, and we are. It's actually very interesting, evolution as a science, because a lot of what we know about our history and our descent is actually it's a bit like a jigsaw with a million missing pieces, and we have a very small number of pieces, and what we do is try and fill in the gaps for the answers. But the reality is a lot of it is very theoretical. There are a lot of different people that have different opinions about evolution. So firstly, I wanted to talk to you a little bit about the age of humans. So Homo sapiens are thought to have been around for about the last 200,000 years on Earth, and in our form, essentially, the early Homo sapien form. There's been some degree of evolution since then, of course. But that's actually very recent when you think about the history of Earth. And really, when you think about us as modern humans, really, in the last 40,000 years, we haven't changed that much. the thing is, we don't actually know precisely what species we originated from, and paleontologists used to think that there was the out of Africa hypothesis, so there was this idea, so we know that our very early human findings, our earliest is about 160,000 years ago, and is Lucy, the skeleton, so she was found in Africa, and pieced together from there, and scientists thought that there was this out of Africa hypothesis, that there was this serendipitous time in Earth's life when these early humans could migrate from Africa out all the way to Europe, which is a very long way. And when we got to Europe, we came across some Neanderthal counterparts. And we used to think that actually Neanderthals were completely separate from us, from Homo sapiens. We didn't have anything to do with them. We stole their food, we stole their homes, we were better than them. So we basically took them over. But actually, and a very recent Nature paper was released that has shown actually it's almost cohabited with Neanderthals, and Neanderthals are so integral in our modern day humans DNA, so you and me and almost everyone of all races, that actually we were living seemingly in synchrony. So it wasn't quite what we once believed it was. And the things that have made our species as Homo sapiens so much better, I suppose, and so much able to live longer and spread out more than any other species really in comparison, is put down to partly our social ability, our ability to communicate with each other, and also our need to be with other people. We all with our friends and family, being on your own, we all know is difficult, and actually that's something that's made us really, really strong as a species, is our reliance on communities and families. And that goes all the way back to our very early years, so 40,000 years ago. That is what enabled us to survive, essentially. Other elements that helped Homo sapiens survive out of, their other allied species that weren't too dissimilar from them, was things like tool use. And actually, our tool use as humans and as Homo sapiens was the most sophisticated, and it was our ability to identify a need for a tool, to then create the tool, make the tool more and more sophisticated. This is in a generation, and then pass on those skills to their young and their children, and then pass it on down generations. That is something so pretty unique to Homo sapiens that made them successful. And a lot of other animals, like chimpanzees, for example, they do use tools, but they're not actually able to teach they're not able to pass it down through generations to evolve it and develop it each time. So that is certainly, and who knows why that is the case. And actually brain size does not link to intelligence. There are Neanderthals who almost had sort of very similar sized brain to us, and technically we were more intelligent. So it's not all about brain size. That's not the only thing. I think it was just I think our social elements had a big part to it in helping us survive. So that's very much talking about a sort of history of humans a very long time ago, and well, relatively not that long ago in Earth's life. But I think evolution is really important to think about in more modern times as well, because if you imagine medicine 100 years ago, in the early 1900s, imagine the wars, for example. People died of infection. They died from gunshot wounds that weren't treated. They weren't given antibiotics. They weren't properly amputated like they should have been to get rid of the dead, nasty tissue. like such basic things that we take so for granted now. The fact that you can, if you're not well, if you have a bit of a cough, you could go to your GP, and if they think it's a chest infection that's bacterially caused, they'll give you some antibiotics. It was those simple things that killed people 100 years ago. They died from infections. They didn't die from heart disease. They didn't die from strokes or ischemic strokes anyway. They died from really simple things. So the fact that if you think about 100 years in the context of life on Earth, 100 years really isn't very long. And people don't very rarely die from simple infections these days. Sepsis, you may have heard of, is such an important campaign. And sepsis is essentially bacteria in the blood that leads to multi-organ failure and potentially death. There are still deaths from sepsis, granted, but a lot fewer than there ever were. And actually, people nowadays are living so much longer than they would have done when 100 years ago. Women are living to their 80. Last count, I want to say 83 or 84 for women. That is average life expectancy, and for men, average life expectancy is a little bit lower. Life expectancy does depend on where you live. There are regional variations, which are quite interesting. But we're dying from such different diseases, and essentially 100 years is not enough time to evolve. And there are different schools of thought that perhaps one day we might evolve out of cancer. Like, imagine that. And I mean, childhood cancers are particularly interesting because they are often not environmental. They're often from the embryo. You have a cancer that develops cells that are out of control. And there are thoughts, maybe one day we will grow out of childhood cancers. Like, as humans, we will realize it's not good for such young to be lost at such an early age. So maybe, or like, we don't know. And I think that it is exciting. I think it's not exciting enough to impact on our lives, on our working lives, on your working lives as medics. You are not going to see the effect of evolution, unfortunately. But I think we do have to pay attention to it and think about it in the way that we manage patients. I spoke a little bit last time about lifestyle and the importance of lifestyle in health and disease, and actually we have this culture where we eat too much, we drink too much, people still smoke too much. It's all, it's we need to get out of that in order to ensure the longevity of our generation. There are more and more children with obesity that should never, we don't know what that's going to be like in 20, 40, 50 years. We don't know, is the honest answer, and it is scary. And so I think we need to pay some respect to evolution, to be honest. I think it's really fascinating, and Professor Roberts does the most incredible series on the BBC about evolution. And I would highly recommend watching it because it gives such insight into medicine and people. So certainly one to watch for you, I would say. So yeah, if you have any questions or you're just interested, put it in the box and I'll try my very best to answer it for you. The final thing I wanted to cover was the SJT. So I wanted to make sure that you all knew what I was talking about. So let's have a look. So imagine it's a Monday morning and you, as the Foundation Year 1 doctor, are leading the ward round. You've just finished taking some bloods from a patient. Oh no, sorry. No, I'm reading you the wrong one. I'm giving you a sneak insight into the next one. Sorry, guys. Goodness me. Right, it's November one I want. Goodness me, right, you've got a sneak insight now. Sorry about that. Let's have a little look. This is the one. This is what I want. Okay, right. It's imagine you are the junior dentist at your practice. So this is like Dr. Uppal. It's been a long day, your seniors have already left, and you're just finishing a few jobs before you leave. Your senior had asked you to prescribe prophylactic antibiotics for a patient due to have a dental implant tomorrow. But he didn't give you a reason, and unfortunately, you didn't ask why. You've assisted with numerous dental implants in the past, and you've never given antibiotics before, so you can't understand why you're doing it now. You have a quick look through the patient's notes. You see that they had a heart transplant when they were very young, and suspect this could be the reason for needing the antibiotics prophylactically, i.e., preventative antibiotics. However, you have no idea what antibiotic to give or what dose, and you don't have a local guideline to hand that you can follow. So what should you do in order of most appropriate to least appropriate? So this might sound like a scary situation, but it's very common. You know, as a doctor, as a dentist, as a vet, you will work out of hours and not have somebody to hand to ask about something like this. So what you have to do is use your own resources as much as possible to come to a safe solution. So in this case, I mean, obviously you've never dealt with this before. If you are the most junior doctor or the most junior dentist, if you've only been working for a year, as doctors do, that you only have a provisional license with the GMC. So certainly if this was me and I really didn't know what to do and I didn't have any other means, I would ring my senior out of hours. Obviously, it's not ideal to do that. They might not be all that pleased with you, but it's the safest thing you can possibly do, because even if they don't know the precise antibiotic, they can tell you which guideline to follow or which protocol to follow. So that is the most important thing you could do in this situation. The second most important thing then is perhaps to use national guidelines. Now, national guidelines are often long, they're hefty to read through. You have to sort of read them very carefully to make sure they are entirely related to your patient. And, you know, your patient might have a contraindication to a particular form of treatment that, you know, isn't covered in the guideline. So actually, I mean, it's a good step. It's evidence-based practice would be to use a guideline, but it's not the safest. It's still safe, but not the safest thing you could do in this case. So that's the second thing. The third thing you could do is to look in the BNF. Now, the BNF, the British National Formulary, is our prescribing Bible, if you like. So it has all the drugs that we use in NHS practice, and it's updated every 6 months or so, and it's fantastic. It has the drug, the brand, it has the ingredients, it has the side effects, it has the contraindications, the indications, cautionary prescriptions like people who are pregnant, people with heart disease, heart failure, liver failure, kidney failure. It is everything you could need to know about a drug is in the BNF, usually speaking. Now you could do that. The issue is the BNF will realistically list probably, I don't know, I'm guessing maybe 10 antibiotics you could give for dental implant prophylaxis. So actually, it's a little bit of a guessing game to use the BNF. It's not ideal. So, you know, the other two that we've talked about would be much more suitable. Now, the fourth option that really isn't appropriate would be to ask the dental nurse practitioner. Now, they may well know. The issue is they're not prescribers at the end of the day, and any prescription that you write is your responsibility. And you know, nurses tend to work on protocols. They know what they're used to. They know what the majority of patients would give. But just giving it because it's what they normally use isn't really good enough, isn't really safe enough in this case. So actually, you'd need to go a little bit above and beyond that to make sure you're giving the right antibiotic. And then the final, the least appropriate, and I hope you could all see that this is inappropriate. When your senior has asked you to do something, it's because they have more expertise than you. They know what needs to be done, and you are obliged to follow, your supervisors know. Obviously, if you don't agree with it, then perhaps it needs a bit more interrogation as to why your senior thought that, or maybe you need to find a bit more information. But generally speaking, your supervisors are the experts, and if they advise something, you should do your utmost to ensure that happens. So just not giving the antibiotics, it puts the patient at risk, because if he comes in tomorrow and has the surgery, he hasn't had the preventative antibiotics, so he's at risk of infection. And when we're talking about infection, we're talking about a deep-seated infection, like infection of the valves of the heart, called infective endocarditis. Very serious condition. You can die from that, you can develop sepsis from that, and very serious long-term consequences potentially. So it's not to be undermined. So that's certainly the least appropriate thing to do. Okay, so I think that's everything I wanted to cover. I can actually see one little question here. Just wondering what the under the tongue spray. Oh yes. Okay. No, good question. So if somebody's having a heart attack, the first thing you should do is ring 999. The paramedics will come, they will do an ECG, they will assess the chest pain, and one of the first things they will give is a GTN spray, so glycerol trinitrate. So you might have seen it, is where the patient lifts up their tongue, they put it underneath the tongue, 2 sprays, and if it's true cardiac chest pain, the pain should be relieved and almost go away within a couple of minutes. So usually a minute, no more than 3 minutes, you should see an effect. So the pain is relieved. Realistically, with a proper heart attack, like a big ST elevation heart attack, one of the big ones, GTN might help a little bit, but it's not going to take the pain away, to be honest, very much. The way GTN works is it's essentially a vasodilator. So vasodilators, so that loosens the muscle around the coronary arteries, relaxes the muscle, helps to try and open up the vessel, increase the blood supply to the heart. And there are collateral supplies. So, if one vessel is completely blocked, if you can increase supply to the other vessel going into the heart, at least you've got a bit better blood supply then. So that's the GTN spray. So you can give it as a spray. You can also give it as like an IV infusion when they come in. So some patients might have that. That's often quite helpful for sometimes in heart failure. You can use that as well as a vasodilator type action. So he had that was the GTN spray he had. Also the aspirin. So he had 4 tablets of aspirin. That's what we give for all heart attacks straight away. They also need another antiplatelet drug, so a drug that essentially stops the platelets from clotting together. They're one of your main clotting agents. So aspirin's important, and then something like clopidogrel, ticagrelor, prasugrel. They're your other dual. So you give dual therapy usually in a proper heart attack. And then other things they'll give, things like a beta blocker, a blood pressure tablet, getting on top of blood pressure, getting on top of cholesterol with your statins, and then getting on top of diabetes control. So good question. I'm sorry I didn't cover that. So I think that's everything from me for this webinar. I hope you enjoyed the study guide. The January study guide is ready to go. So from my end, all the content's done for it. You had a sneak peek already. So they're just going to make it beautiful for me, and then we'll get that sent out to you in very early January. I appreciate that it was a bit of a rush for this time, so it's so good to see the 10 of you with us tonight. Thank you so much for joining. I hope these are really useful. We're really keen to get your feedback about these sessions. If there's something you like or something you don't like, please make sure, please absolutely make sure that you can email me. My email's on the website. I'd like to know how to make these as effective and helpful for you as is possible. So if you have an idea for an improvement, I would love to hear it. I've just noticed one more question. Am I right in saying that the pains in his chest previously was stable angina? Exactly, that's exactly right, yes. So very classically, patients, if they walking the dog or a brisk walk or something like that, they will get a pain that comes on, they then have a bit of a rest for a couple of minutes, and the pain goes away completely. And it's because when you're exercising and active, your heart is working a lot harder, it's beating faster, it needs a better blood supply. So that is when the pain goes away on its own without treatment, goes away after a couple of minutes rest, that is stable angina, exactly right. It's stable, it's not going to form a clot, you're not worried, Now, stable angina can progress and become acute coronary syndrome. So stable angina can become unstable angina, which is where you have got a partial obstruction. Quite commonly if you don't give the right treatment. But actually, in real clinical practice, having been on a heart assessment unit, it's actually often very difficult to sometimes tell what type of ACS it is, if it's unstable, if it's stable, if it is heart attack. So often we treat if they have a lot of risk factors, we'll do the imaging for them, like a CT coronary angiogram, which is where we light up the vessels in the heart to look for any blockage. It's obviously a lot less invasive than the actual angioplasty procedure where we put a wire in, but it actually gives us a lot of information about how healthy the vessels are in the heart. So yes, so very, very good point. And yes, he had stable angina, which had progressed to unstable angina in this case. If you were to have ECG changes, that's when you're branching into your a non-ST elevation MI or ST elevation MI. Great. Oh, well, thank you for your questions. It was really nice to see a few of them tonight. As I say, we're looking to get these made available to you so you can watch them back. Do email me. It's vpeducation@medicmentor.org. Anything you need, just let me know. I'm happy to answer any questions you have as well about your application process. I know many of you will have exams coming up after Christmas. I wish you the very best of luck with those. Do make sure you get some time off over Christmas as well. You need R&R and recuperation in between as well. And for those of you, I hope you all have a wonderful and festive season. Merry Christmas to all of you. And I wish you all a very happy new year. And thank you for joining us. All right. Good night.